Hello Pericos, welcome back to my channel. So the last time we basically discussed about the congenital heart diseases, and I hope you guys have already gone through the last video and have understood what all we discussed last. So in the last video we also discussed about the ventricular septal defect, and we came to know that it is the most common congenital heart disease overall. So in today's video we'll be discussing about the atrial septal defect. Just to let you know that ASD or the atrial septal defect is a well tolerated lesion, okay, and this lesion is mostly, it is the most common congenital heart defect to be present in pregnancy or like during adulthood. So moving forward, the ASD, first of all, the types of ASD, let's discuss that. So it is of 4 types. We have the ostium secundum ASD, we have the ostium primum ASD, we have the sinus venosus ASD, and the coronary sinus ASD. So this one, you can see here this lesion, this is the ostium secundum, this is the ostium primum, this is the sinus venosus, and this is the coronary sinus. You must be knowing from your innate revision classes that coronary sinus is basically where the whole of the heart basically venous drainage happens. So between this ostium secundum and ostium primum, this gap is called as the foramen ovale. Just a little information I'm delivering here. Okay, now let's discuss about the pathophysiology of ASD. Okay, before that, one more thing, that ostium primum, this ostium primum is associated with increased risk of mitral valve defects like mitral regurgitation or the mitral valve prolapse. Okay, the ostium primum. Right. Now what about the pathophysiology? Now in the normal heart, we already discussed the last time that from the superior vena cava and the inferior vena cava, the right atrium will be receiving the blood from whole of the body. It will be moving to the right ventricle, that will moving through the pulmonary trunk to the lungs. From the lungs, the oxygenated blood will come to the left atrium, that will move to the left ventricle, and that will move to the aorta and then to the systemic circulation. This we already knew. But what's happening in atrial septal defect is basically in between the left atrium and the right atrium we have a defect. Okay, you can see here this is the defect. So it's also a shunt between the left side of the heart and the right side of the heart. Since you already know that the left side of the heart has higher pressure, so the blood from the left atrium will be shunted to the right chamber of the heart. Now since the right chamber of the heart will be receiving more amount of blood than normal, it will then move to the right ventricle. Right ventricle will be receiving more blood than normal. This will then move to the pulmonary trunk, which will also be receiving more amount than normal, and so on. Okay, now what about the murmurs? There's a difference between VSD and ASD that in there are a lot of differences, but one difference that I want to tell here is that in VSD you were seeing a pansystolic murmur, right, which was the shunt murmur. But in case of ASD there is no pansystolic murmur. Okay, so why is it so? Now this is because the right atrium of the left atrium of the heart does not have as much amount of blood as compared to the left ventricle of the heart, right? So when the blood moves from the left atrium to the right atrium, there is not enough blood that can create a turbulence for the pansystolic murmur to occur. Therefore there is no shunt murmur here. But yes, we definitely have two flow murmurs as we previously read about. One is the ejection systolic murmur, another one is a delayed diastolic murmur. So when the blood from the left atrium reaches the right atrium, so this increased volume of blood crosses this tricuspid wall to the right ventricle. So right ventricle is in diastole, is receiving more amount of blood as compared to normal. Therefore, from this tricuspid wall, there will be a delayed diastolic murmur. A diastolic murmur, why? Because the ventricles are in diastole. Okay. Now when the blood from the right ventricle will move through the pulmonary wall to the pulmonary trunk, now again from this normal wall, more higher volume of blood is passing, that will create turbulence, and here there will be an ejection systolic murmur. And why systolic? Because the ventricles are now contracting. I hope this is clear. If not, please let me know in the comment sections so that I can, you know, can improve more. Okay, now let's move further. So this we already discussed the two types of murmur. Already told you that there is no shunt murmur. Okay, but yes, we are definitely having the flow murmurs, the ejection systolic murmur and the delayed diastolic murmur. The delayed diastolic murmur occurring at the level of the tricuspid valve, and the ejection systolic murmur occurring at the level of the pulmonary valve. Okay, now there's one more thing that you must know. Yeah, that is, in ASD we have a wide fixed split S2. Now you know S2 is the second heart sound. Okay, now how is normally S2 heard? It is because of the closure of the aortic and the pulmonary valves, right? So what happens normally is that during expiration we do not hear any split. Okay, but during inspiration there is a split in between the A2 and P2. There are two components of S2. Now you must be knowing about that. Okay, now why is this happening, that during inspiration you are hearing a split, but during expiration there is no split? Okay, that too normally, because when you are inspiring there is increased venous return to the heart. Okay, because of the increased negative interthoracic pressure, there's increased venous return to the heart, and so more blood will be entering the right atrium during inspiration. That will reach to the right ventricle, and then that will reach the pulmonary artery, and hence for pulmonary artery during inspiration is receiving more amount of blood, hence for delayed closure, hence for this split. But what happens in ASD, we'll be hearing this wide fixed split in S2 in both expiration and inspiration. And this is why, because in inspiration already, during inspiration we are receiving more amount of blood, right? But in ASD during expiration also, the left atrium is the left atrium will be sending the blood, will be shunting the blood to the right atrium, then to the right ventricle, pulmonary artery, and henceforth splitting will be present, but it's only in ASD. Okay, now what other conditions do we see this wide fixed split in S2? So one condition is ASD. Okay, another condition is the right bundle branch block, and another condition is TAP VC, that is total anomalous pulmonary venous connection. About TAP VC we'll be studying in our further videos, right? So what about the treatment? So obviously medical management will be to treat the complication, that is congestive cardiac failure, with digoxin and furosemide. But what about surgical management? Do we require surgical management in ASD? Now if the ASD is less than 8 mm and it is asymptomatic, then this ASD will undergo spontaneous closure. Okay, and we need to make sure that it undergoes spontaneous closure, and if it does not, then we need to make sure that before the child goes to the school, that is before 4 years of age, we should basically close it if it hasn't undergone spontaneous closure. But if the ASD is of more than 8 mm, or it is symptomatic, or it is less than 8 mm but it persists for more than 6 years, or the QP by QS ratio that we discussed in the last video is more than 2:1, then definitely you will have to go for the indications for surgery. You will have to go for closure. You can go for a patch closure, right? Now what about the complications? Complications are same as compared to VSD. They'll be having pulmonary congestion that will lead to recurrent pneumonia. There'll be congestive cardiac failure, infective endocarditis. But remember that the incidence of infective endocarditis in ASD is least, right? And in very severe cases of ASD, they can also have Eisenmenger syndrome. And the complications, they usually occur in 3rd to 4th decade of life. Okay, I hope you got a little idea about ASD. I mean, it helped you in revising your topic. This must not be the best video on the internet right now, but definitely it will be helpful for those who just want to revise passively. So do support my channel. Make sure to subscribe and like the videos, and I'll be uploading such videos every weekend. And okay, see you in the next video.